Next speaker is Dr. DJ Lakreddy. He's going to talk to us about how not to get fried in the EP lab.
Thank you, Madhu. So this, I think, is an interesting topic that we tend to accept, but at the same time, we tend to really not care a whole lot about, because at the end of the day, you want to get your procedure done, then oftentimes we sort of sideline a lot of these safety measures that we want to do. So EP tools back in 1990s, when Dr. Sanjeev Saxena and Al Waldo and all these stalwarts really started their electrophysiology careers, the life of an electrophysiologist was relatively simple. You had a fluoro machine and you had a few catheters. Most of the times they were straight catheters that they did a lot of tricks to really put them in all those places they really put them in. And then it was quite acceptable to be irradiated left and right, and your hair was falling off. There was skin ulcers on your hands and feet. That was still acceptable, and you were thought to be tough. And then came a revolution over the next 2 decades. We invented a lot of devices, a lot of cool toys, tools. But for some reason, we still are critically dependent on this one unit called fluoroscopy. And I don't think we really made that much of a progress, despite all the new tools and toys we have in our hands now. So what I'm going to focus now is, how did this whole interventional cardiovascular field really evolve, and why is it that we are so addicted to fluoroscopy, and why is it that we are so critically dependent on fluoroscopy? If you look at that, in the degree to which the fluoroscopic exposure has gone up is just dramatic, almost. We used twice as much fluoro in 2013 than what we did in 1988. And it's partly because the complexity of the procedures has dramatically increased, and the things that we can do today is just unbelievable that we were unable to do in the past. All the Afib ablations and the VT ablations, we go into the endocardium, we go into the epicardium, and then we essentially live in the heart for the longest of the time. As Dr. Saxena was pointing out, we learned a way to really immerse ourselves in the most complexity of these things, and more fluoro we spend. Even though the percentage of the cardiovascular interventions in the entire field of interventional radiology and cardiology is about 12%, it's quite amazing to see that 48% of the total fluoroscopic exposure that comes from any kind of interventional procedure is actually related to cardiovascular interventions. And an average patient that gets admitted to a cardiovascular unit, if you by any chance is a cardiovascular patient, there is a statistic out there that in a patient's lifetime, there are about 36 examinations that are done exposing an individual patient to about 60.6 millisieverts of radiation. If you really look at it, somebody comes in with atrial fibrillation to an ER. They do an X-ray. They do a CT scan to just make sure there is no pulmonary embolism. And by golly, you had troponin elevations, then you get a nuclear scan. Oh, nuclear scan is abnormal. Then they get a heart cath. And then they come and see the electrophysiologist, who's going to do a bunch of cardioversions on them, and then they're going to set them up for a cardiac ablation. Then you get a CT scan, then you get 50, 60 minutes of fluoroscopic radiation. Oh, by the way, the procedure requires a second touch-up ablation. You go back in for another CT, another ablation, and another CT. By the time you count all of these things, I think the patient does get exposed to a lot of radiation in the mean process. So why is radiation dangerous to us? I think the classic example that everybody has on their minds is the Hiroshima and Nagasaki. I think a lot of us were not even born at the time. But I think that's the biggest impression that you get, the big nuclear cloud that comes up. And the ionizing radiation that comes from that essentially affects your DNA, your lipid structuring, and then the proteins. There are a significant number of intracellular changes that happen that essentially leads to all the sequelae that we come across that are mostly categorized into 2 parts. The effects of ionizing radiation could be broadly divided into stochastic effects and deterministic effects. When you say stochastic effects, as the dose increases, the probability that cancer or a genetic effect will occur also increases. And unfortunately, there is no threshold below which it is relatively certain that an adverse effect cannot occur. So that means you're doomed one way or the other. Deterministic effects is, yes, it is dose dependent, but again, there is at least certain threshold beyond which that you should be exposed in order to have that particular side effect. So what are some of those things? So things like cancer, leukemia, genetic defects, kids born with no legs, no hands and ears, cataracts, sort of fit into that stochastic effects. And then those who sustain tissue burns, hair loss, sterility, vasculitis, death, and other things are probably come under deterministic effects. So at the end of the day, I think there's no magnitude of radiation exposure that is known to be completely safe. This principle confers a responsibility on all physicians and operators to minimize the radiation injury to their patients, to their professional staff, and to themselves. I think this is essentially the Alara Principle, which is as low as reasonably achievable. How many labs around the country really have the Alara Principle written anywhere in their entire lab? As low as reasonably achievable. Very simple abbreviation that should potentially hang in every lab. I mean, every place that we operate, that should be a constant reminder to all of us. And I don't think we really think about it that seriously. If you look at some of the guidelines or the dose effects, I mean, it doesn't really require a lot of radiation for people to really develop cancers and other side effects in the long term. I mean, if you look at the effective dose of 1/200th of 100 millisieverts is what is needed for causing fatal cancers. And if you look at the deterministic effects, more than 350 grays per centimeter square is what results in those bad necrotic skin ulcers that are difficult to heal. So obviously there is a disagreement between the US and European governments in what they consider to be the acceptable minimum dose of exposure. And who is at risk? It's the patients, it's obviously the operator, and then the support staff who actually help us out in getting these procedures done that are at extreme risk. So if you look at this, I mean, this really reminds you of a really bad plastic surgery job, right? Unfortunately, this was a patient who actually had multiple angiograms in his lifetime, and this is exactly what happened to one of these patients. Quite recently, I was actually asked to be an expert witness on a case of radiation injury related to an atrial fibrillation ablation, supposedly where the patient was exposed to 150 minutes of fluoroscopy in one case. And I mean, that's just mind-boggling. I mean, we do not know the circumstances under which this has happened, but again, this goes to tell you that these things are real and they do happen. So if you look at the entire physician cohort, I think interventional cardiologists or electrophysiologists are the one that top the list hands down. I think at least in the last 10 years, with the advances that we have in clinical electrophysiology, with Afib ablations and VTs going up, I think electrophysiologists definitely outdo the interventional cardiologists on any given day. And if you look at the different types of tests that are done and the trends in radiation dose, it is quite concerning that the amount of ionizing radiation that we consume, and that is and these different cardiac procedures that are outlined there are a clear reflection of what's going on. If you take an interventional radiologist who is to your left and then an interventional cardiologist to your right, their exposures for a given case may be similar, but I think all in all, the interventional cardiologists seem to be exposed to a lot more radiation than an average interventional radiologist. So this is an interesting slide. It's like Madhu's twin brother, right? So these were two twin brothers. Which of those two do you think is the smartest? The guy in the scrubs or the guy who has this nice wavy hair looking all nice? And you look at him, I mean, the guy in scrubs has lost all of his hair. I mean, he looks depressed. I mean, he has no glow on his face. But this is the crazy interventional cardiologist's twin brother who actually made a decision to become an interventionalist. And the guy to the left is the cool investment banker who's really having a time of his life, right? So, very true. So, this is a real example of a 37-year-old monozygotic twins. The first twin is a lawyer. Interventional cardiologist is on the right side, as you see. And obviously, over a period of 10 years of exposure, twin 2 had about 7 chromosome breaks and twin 1 only had 1. I mean, that essentially reflects the seriousness with which we are operating in our labs. If you look at the dosimetric results per procedure per operator in most of these catheter ablations, I mean, whichever way you look at it, we are exposed to a lot of radiation. So, and if you look at the calculated risk of fatal cancers in a given interventional lab, obviously the primary operator who is closest to the gantry takes the most hit with about 3 times 10 power of minus 6. The assistant operator, the fellow, or the assistant about 2.5. The technicians who are a little bit farther away are 2.3, and the nurse who is actually behind does get enough of radiation. And there are some very alarming reports that have come out in the last decade or so, and especially the one that was published in 2012. So there was a cluster of 3 brain gliomas and 1 meningioma, especially on the left side in interventional cardiologists. So I don't know how many of the electrophysiologists at this point, if you really screen them and do brain MRIs on all of us, I don't know what else we're going to find today. So this is another example of how the radiation exposure can lead to brain cancers. I mean, for the longest of the time, there is a myth out there that somehow the bone protects your brain and you don't really need to worry about your brain. You can actually expose yourself to everything else. And somebody very creatively came up with a skull cap, an example that we will show down in the next few slides. So we talk a lot about fluoroscopy, radiation, ionization, and everything else, but I think the orthopedic issues are actually far less ignored. An average operator and supporting staff in the CV lab wears lead protection suit that weighs about 15 to 25 pounds. I mean, I think we have gotten better at this. Back in the day when Gary Beecham and Dr. Jim Wasik were doing CATs, their blades probably weighed about 30 pounds. And I mean, right now ours weigh about 12, 13 pounds, I think, 10, maybe 10 pounds. Yeah. And it can place up to 300 pounds of pressure per square inch on a physician's intervertebral disc, and this pressure can be aggravated by improper table height and all the other factors that come along with that. As a result of which, there are about 42% of invasive cardiologists who report a back problem in their lifetime. And about 1/3 of these people actually miss work due to spine problems, and 26% develop either cervical or lumbar spondylosis very early, putting an end to their revered career and imposing a significant amount of economic impact on the system. We put in all this money to train these interventional cardiologists and electrophysiologists, and their careers actually get short very, very quickly. And the cost of taking care of these back injuries, both from a medical as well as a medical legal standpoint, is actually significant. So if you look at the direct and the indirect costs of increased radiation exposure, there are definitely physician-related factors. And then there are the short-term effects of sitting out from increased exposure and the midterm effects of orthopedic problems, and then the long-term risk of cancers, vasculitis, and the medical problems. And its impact on society in general, looking at the total cumulative health, social, and economic burden that it brings on is worth looking into. So how to really tackle this problem? I think we've been doing a lot of different things, but I think putting everything together as a comprehensive program seems to make most sense. We have a lot of protection tools. We have improved our system parameters. That is, we have done a lot of work that improved the amount of radiation that a gantry spews out. And we also have invented a lot of new technologies that can be surrogates for fluoroscopy, depending on how well and effectively we use them. So, for example, the personal protection systems. I mean, we have lead aprons, we have glasses and surgical drapes and so forth. But then again, how effectively do we use them? And how effectively do we make sure that these lead actually is protecting us, and are there cracks in the lead, and how timely do we really check them? I think these are all the important factors that the managers of the lab should make sure that they're working on. I mean, wearing radiation protection glasses. I see a lot of us don't wear these on a consistent basis. I mean, I'm to admit that maybe I wear my lead glasses about 60% of the times. Whenever it's a shorter procedure, I'm more likely to say, oh, I'm just going to be in and out quick. Maybe that's a pattern that I really need to work on myself. And oftentimes your glasses are so ugly and so heavy, like the one that's on the top the guy is wearing, you're not incentivized to wear them. So maybe everybody should get some cool glasses like the girl down below. And I think when Rad Pants initially came out, I didn't really believe that this was really going to make a big difference. I mean, but as the data came out, it's unbelievable. I mean, it's 54% reduction in effective dose exposure. I mean, that's a tremendous number. I think that's something that we all have to really think about closely. And then there are these ergonomic radiation protection suits, or what everybody calls them the space suit. So the French guys came up with this cath pack system that's a little bit, I mean, clunky, cluttery. It's hard to move around. And so we kind of looked at it. We didn't adapt it. And then we actually got this zero gravity system. So that's actually me in picture C. So it actually works really good. I like my zero gravity system because it just takes away all the weight from your shoulders, and it's so much easier to just stand behind it attached with a tiny magnet to the whole system. And I greatly appreciated that one purchase for our lab. And I think a lot of my partners, I actually agree with that too, even though they need to make it a little bit more useful from RIA standpoint.
Nobody can hear me when I yell.
And then so we have the three-dimensional electroanatomic mapping systems that came around. I think since the early 1990s, we have gone through several iterations of this. Now we have 3 major systems in place. And effective use of these three-dimensional electroanatomic systems seem to have been very helpful in decreasing the radiation doses anywhere from 20 to 30%, depending on which data set that you look at. Similarly, for simple flutter ablation cases, we have a similar reduction. And then back in 2008, we actually put out a very an interesting paper, small, looking at comprehensive radiation protection program, where we enforce people to really look at their radiation numbers. The lab manager would stand in front of the lab as attending gets scrubbed in. She tells Andrea, this was your radiation for the last 4 cases. This was when I was a fellow back in Cleveland Clinic. We did this. Or she would come up to Dave Burkhart and say, hey, Dave, this was your number for the last 4 cases, kind of giving that number to put it in your brain that maybe we need to go a little bit light on our foot and move away from the iron foot tendencies that we all tend to have. And I mean, that seemed to really help the overall exposure, even though we were not that very successful in making a dramatic reduction. And then what else has come forward to really help us out? I think miniaturization of technology has really pushed the envelope a little bit. If you look at these sensors that are as big as Abraham Lincoln on a penny, that really opens up a lot of opportunities. And this is where the new technology called the MetaGuide comes into play. So imagine a geo-positioning system where you have basically a source of electromagnetic localization, and then you have a sensor, and then that sensor is localized in that given electromagnetic field, and then you move around, and that obviously picks up, and then it gives you a positional reference, and then the actual position of the catheter tip. And that's essentially how this system simplistically works. We were one of the first in the country to get this system, and we have put it to very effective use. And on average, the use of MetaGuide system results in about 40 to 60% reduction of fluoroscopic doses in CRT cases. And you do really find similar usage in the ablation cases as well. What you see here is a fluoro picture. The green dot and the yellow dot are representations of the catheter tips, one that is sitting in the SVC, one that's sitting in the coronary sinus. You can use any number of catheters that you want. This is a case of atrial flutter ablation, where you see the ablation catheter on the left, and then you have the CS catheter. And those pink marks are the standard references that you put on the fluoroscopic unit that would help you. I mean, this was done in combination with a Navix map, and an example of that particular flutter case where we have used less than 3 minutes of fluoroscopy. And then what are some of the other things that can be done to eliminate the risk of excessive fluoroscopic exposure? Is basically the changes that you brought into the system itself. I mean, eliminating the grid and decreasing the pulse frequency. In a lot of places, they use about 30 frames per second. Do we really need 30 frames per second? Can we get away with something lesser? I was actually amazed to see some of the work that was done by the Europeans where actually they use 2 frames per second exposure. I mean, I thought maybe we'll die of a seizure, but obviously they are able to do that. I think collimation is another big thing that we tend to forget, right? I mean, if you really collimate it effectively, you could potentially decrease the amount of fluoro that comes out and that you get exposed to about 1/4. And I think there's no reason you really need that entire screen to be lit up. You could actually bring your shutters in to the area that you want to work in, focus in, and thereby minimize the amount of exposure in a big way. So fluoroscopy times and radiation exposures are definitely better. In a series that was published by Gerhard Heinrich's group, they have seen reductions anywhere from 30% to 95%, depending on what series you look at. And as they've had it for about 3.5 years now, and I think right at this point in time, their fluoroscopic exposures are down from an average of about 35 minutes per case of Afib to less than 3 minutes for an average case of atrial fibrillation. Those are dramatic changes and shifts forwards. So this is our own experience here at KU, what we call the less RADS registry. RADS for radiation, so less radiation. So this is our initial results with atrial flutters and supraventricular tachycardias. And what we have noticed is it's not trivial. I mean, it kind of, when we looked at the cumulative numbers, it didn't look that impressive, but when we really crunched the numbers, there was a 61% reduction in the cumulative fluoroscopy time, 27% reduction even in the procedural times, and 62% reductions in fluoro density and fluoro quantity. This is just with diagnostic catheters even before we even had our hands on the ablation catheter. So these are, again, slides that show the differences in fluoroscopy time. This is an example of AF ablation with the MetaGuide, where there is an effective use of the new MetaGuide system with the Navix. And the preliminary data is very compelling. And there are some initial case reports and case series on VT ablation as well. This is, I think, another area where there is a significant amount of fluoroscopy consumed. Radiation exposure is high, and I think there are new strides using the MetaGuide technology in that in a much bigger way. Does the operator really matter? I think, yes, everybody has a different style of how they come and how they operate. And I think even for those that have a lead foot, this makes a tremendous difference. And that benefit seems to be pretty uniform. And it's interesting that it's even time dependent. I think when we initially started off with the MetaGuide system, our numbers in general were high, even for those non-MetaGuide cases. We're talking about the MetaGuide connection cases. As you see here in green, the amount of fluoroscopy that we use even for the conventional non-MetaGuide cases seems to really come down. I think we become more conscious and we become more in tune with the concept of kind of protecting ourselves and working with those. And all the fellows always wonder, oh, I'm his radiation shield. I'm getting burnt out, and I think even the fellows actually benefit from this because of how much it comes down. So obviously, there are a lot of things that can be done within the systems by adjusting the grid, pulse frequency, collimation, and using things like the last image holes, spectral filters, and so forth. I think this could potentially be of greater help, and maybe it's time for each of us to go back and ask our lab managers to really look into this one more time and then program them to the least common denominator so that we are exposed to the least amount of radiation. We talked about this pulse frequency before. And if you really look at that, the secondary grid, without grid and with grid, and where the without grid essentially gives you the least amount of radiation there. And there's really not much of a difference in the quality of the image there. However, the amount of the cumulative dose of radiation that you minimize is actually significantly higher. So simple techniques like that can go a long way. So with that, I conclude, and I would like to invite you to the Global Atrial Fibrillation Alliance. This is a private-public partnership effort to improve the awareness of the atrial fibrillation around the world and striving towards a world-free atrial fibrillation. And we do have the World Afib Day on September 14th with a yoga and run walk program here in town at Town Center Plaza. We have 4 other cities that are organizing these. And I conclude by inviting you all to the 2nd International Symposium on Left Atrial Appendage in 2014. Thank you.